I am pleased to join you today and would like to start by saying that my views are my own and do not reflect those of everyone at my institution. I am a pediatric rheumatologist caring for children with the multi-system inflammatory syndrome related to COVID-19. I have also taken care of many young people who suffered from coronavirus infection and for others who have experienced complications from vaccination. But I have also cared for many adults who were hospitalized with COVID-19, a number of whom died or were permanently incapacitated because of infection with the SARS-CoV-2 virus. As we passed the landmark this past weekend of at least 5 million people killed worldwide by this pandemic, the value of the vaccines to humanity in preventing death and chronic illness can hardly be disputed. But last December, prior to the first hearing reviewing the clinical trial data for the Pfizer-BioNTech vaccine, I wrote a letter to the FDA urging caution with regard to the rush to vaccinate children. I cited a German prospective study of 100 patients recently recovered from COVID-19, 80% of whom had cardiac involvement on MRI, an average of 2.5 months after recovery, including 2/3 who were never hospitalized. These abnormalities occurred independent of pre-existing conditions and severity of the initial illness. I was concerned about the possibility then that the new mRNA vaccines had the potential to cause unintended side effects related to the heart, since these vaccines encode the same viral spike protein that causes most of the organ damage outside the lungs in people who are actually infected with the virus. We have a much better understanding now of the role viral spike protein plays in both the primary disease and the complications from vaccination. Infection with this virus starts in the nasopharyngeal epithelial cells, where it replicates and probably spreads through the airways into the lungs. Viral replication in the lung endothelial cells lining the blood vessels results in the production of pseudovirions and spike protein that travels through the bloodstream to other organs. The pseudovirions bind to the famous ACE2 protein on cells in the blood vessels of those other organs and activate something called the mannose binding lectin complement activation pathway, leading to microvascular damage and microclots. So it appears that the viral spike protein that is the target of the major vaccines is also a key agent causing the damage to distant organs, which may include the heart, brain, and kidneys. What do we know about the parallels between natural infection and the vaccines with regard to the adverse effects on these other organs? I was a co-author on a new study in Clinics in Dermatology, documenting that the spike protein produced at the site of vaccination, which is usually in the deltoid muscle of the shoulder, travels through the body and can be detected subsequently in the skin of the opposite shoulder. But the levels of spike in the skin after vaccination are much lower than what one sees following natural infection with the virus itself. In other words, the spike glycoprotein does have toxic and procoagulant effects, but apparently only when it is expressed at very high levels. In normal skin biopsies from patients with critical COVID, there are significant levels of spike bound to ACE2 in the fat, with evidence of systemic complement pathway activation, possibly explaining the association with obesity, especially in children. However, following vaccination, normal skin samples show no evidence of complement pathway activation, and the amount of manufactured spike originating in our muscle cells appears to be minimal. The self-limited skin reactions we described in our paper may serve as a model for the rare, severe vaccine reactions that you're hearing about today, probably through hyperactivation of the cellular immune response or overactive antibody responses, or hypersensitivity reactions that are unmasked by the nanolipids in the vaccine vehicle. In my letter to the FDA, I had worried last December about the risk of using the spike protein itself as the active principle in these vaccines. Overall, I've been surprised at how well tolerated the vaccines have been in most people, as hundreds of millions have been vaccinated around the world. As we've seen in adults, proving a cause and effect relationship between vaccination and adverse events is enormously difficult, and it will be even harder in young children who have difficulty articulating what symptoms they're experiencing. As we embark today on a vast experiment vaccinating younger children, whose immune responses to the virus are very different from those in adults, we should resolve as a community that we will keep an open mind about the kinds of physical and behavioral reactions we will be seeing, and not allow ourselves as caregivers to dismiss the concerns of parents. There simply haven't been enough children studied yet to know for sure. I took care of Jonas Salk, Dr. Jonas Salk, the inventor of the polio vaccine, at the end of his life, and I think he would have urged us to vaccinate widely now against COVID-19, but not to abandon caution when it comes to balancing the risks and the benefits. Overall, I think the potential for benefit of vaccinating children is enormous, blocking the spread of the Delta variant from children to vulnerable adults, and preventing the deaths that have occurred across the country in children themselves. Thank you.